If you take a daily medication for blood pressure, and in the past year or two you have noticed that climbing a flight of stairs leaves you more winded than it used to, that your weight has gradually increased without meaningful changes to your eating habits, or that a persistent fatigue sits on top of everything regardless of how much sleep you get, there is something specific in the research you deserve to know. This video is not about telling you a medication class is simply bad, or that you should stop taking what you have been prescribed. Medicine does not work that way, and presenting it that way would be a disservice. What this video is about is a significant shift in the evidence base around one of the most widely prescribed blood pressure medications for older adults, a shift that occurred over the past 2 decades, and the fact that millions of seniors are currently taking a medication that was prescribed years ago without any formal reassessment of whether the current evidence still supports it as the best available option for their specific situation. One statement before anything else, and it requires emphasis. Do not stop taking a beta blocker on your own. Not after this video. Not before speaking with your physician. Stopping a beta blocker abruptly without medical supervision can produce a dangerous rebound effect, a rapid spike in heart rate and blood pressure that in some cases can trigger a heart attack or a serious arrhythmia. Any transition away from a beta blocker must be done gradually, over weeks, under direct physician supervision with regular monitoring. What follows is information and a set of specific questions to bring into a medical conversation. It is not guidance to make changes independently. Beta blockers, known by brand names including Toprol, Lopressa, and Tenormin, and by generic names including metoprolol, atenolol, bisoprolol, and propranolol, have been prescribed for hypertension for over 5 decades. They are inexpensive, familiar, and were for a long time considered the standard first-line treatment for elevated blood pressure. Tens of millions of prescriptions are written for them annually in the United States, a large proportion of them belonging to adults over 60 who have been taking them for years. The mechanism is specific. The surface of heart muscle cells contains receptors, molecular binding sites, to which adrenaline attaches to accelerate heart rate and increase the force of contraction. Beta blockers occupy these receptors competitively, preventing adrenaline from binding. The result is a reduction in heart rate and in the force of each heartbeat, which lowers blood pressure. For certain clinical conditions, recovery following a heart attack, management of heart failure, treatment of specific arrhythmias, this mechanism is precisely what is needed, and the evidence supporting beta blocker use in those contexts is solid and not contested here. The question this video addresses is narrower and more specific. For a senior whose only medical issue is elevated blood pressure with no prior heart attack, no heart failure, and no arrhythmia, what does the current evidence say about beta blockers compared to the alternatives that are now available? The 2017 guidelines published jointly by the American College of Cardiology and the American Heart Association do not list beta blockers as a recommended first-line treatment for uncomplicated hypertension. The 2024 European Society of Cardiology guidelines similarly do not include them in first-line therapy for most patients without specific cardiac indications. The most consequential piece of evidence driving this shift came from a trial called ASCOT, the Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet in 2005. The trial enrolled 19 to 257 patients with high blood pressure and followed them for an average of 5.5 years. It was stopped early because the results met a pre-specified threshold for clinical significance that made continuing the beta blocker arm ethically unjustifiable. The group receiving a calcium channel blocker-based regimen, specifically amlodipine, compared to the group receiving the beta blocker atenolol, showed 23% fewer strokes, 11% lower all-cause mortality, 16% fewer total cardiovascular events, and 30% fewer new cases of diabetes. Scientific precision matters here. Ascot compared atenolol specifically against amlodipine, and there has been legitimate debate about whether all beta blockers carry the same profile as atenolol, or whether newer agents such as carvedilol and nebivolol behave differently. Some evidence does suggest meaningful differences between agents within the class. The European Society of Hypertension in their 2023 update retained beta blockers as an optional first-line therapy, noting the overall benefit data remains substantial. The scientific conversation continues to evolve. What is not contested is this. Beta blocker-based treatment in Ascot was associated with twice the rate of fatigue, significantly more bradycardia, more dizziness, and more shortness of breath than the calcium channel blocker arm. In an older body, each of those consequences carries weight. The metabolic consequences of beta blockers for older adults represent a dimension of this story that receives insufficient attention in routine clinical practice. Beta blockers reduce insulin sensitivity. They raise triglycerides. They lower HDL, the lipoprotein associated with cardiovascular protection. A meta-analysis examining data from approximately 95,000 patients found that people taking beta blockers for hypertension had a meaningfully higher risk of developing new-onset type 2 diabetes compared to those on other antihypertensive medications. In Ascot specifically, the atenolol group showed a 30% higher incidence of new diabetes compared to the amlodipine group. The clinical significance of this finding for seniors is direct. Hypertension and type 2 diabetes together create a combined cardiovascular risk that is substantially greater than either condition alone. A blood pressure medication can produce a controlled reading on the cuff while the metabolic environment underneath that reading is deteriorating, insulin resistance progressing, triglycerides rising, HDL falling. The number on the blood pressure cuff is not the complete picture of cardiovascular risk. A reading of 126/78 can coexist with a metabolic trajectory that is quietly increasing the long-term probability of a cardiovascular event. Most older adults on beta blockers have never been told this. The pattern is recognizable in clinical practice. A patient in their late 60s on a beta blocker for 3 to 4 years, blood pressure controlled on paper, but weight has gradually increased without major dietary change. Fasting blood sugar has drifted higher. Energy is described as a fraction of what it was, and exercise has become progressively harder and less frequent. Each of these changes is attributed to aging. The possibility that the medication is contributing is not raised. The prescription has never been formally reviewed. There is a full risk dimension to this that deserves direct attention, because for older adults it represents one of the most serious safety considerations in geriatric medicine. Beta blockers can produce orthostatic hypotension, the transient drop in blood pressure that occurs when standing from a seated or recumbent position. The brief dizziness associated with standing too quickly is a mild inconvenience at younger ages. In adults in their 70s and 80s, it is a full risk. Research in orthopedic and geriatric medicine journals consistently places the 1-year mortality rate following hip fracture in adults over 70 at approximately 30%. A medication-induced fall is not a minor adverse effect. For an older adult, it can be a life-altering or life-ending event. What does the current evidence support as alternatives for seniors with uncomplicated hypertension? 2 medication classes appear consistently across both American and European guidelines. The first is calcium channel blockers, of which amlodipine is the most commonly prescribed. The Ascot data strongly favored this class. It does not carry the same metabolic burden. It does not restrict maximal heart rate in the way that limits exercise capacity. A 16-year legacy follow-up of Ascot participants, published in The Lancet in 2018, found that patients in the amlodipine-based group had significantly fewer deaths from stroke over the entire follow-up period, a cardiovascular protection that extended more than a decade beyond the original trial. The second class is ACE inhibitors and their related agents called angiotensin receptor blockers, or ARBs. Medications including lisinopril, ramipril, losartan, and valsartan have shown consistent benefit in older populations. They have protective effects on kidney function. They show favorable outcomes in patients managing diabetes or elevated blood sugar. A meta-analysis in the Journal of the American College of Cardiology found ACE inhibitors and ARBs were associated with significantly lower new-onset diabetes risk compared to other antihypertensive classes, a distinction that is clinically meaningful for seniors already managing blood sugar or sitting in the pre-diabetic range. ACE inhibitors produce a persistent dry cough in approximately 10 to 15% of patients. For those patients, an ARB works through a similar mechanism without triggering the cough. The appropriate framing of this entire discussion requires precision because the nuance is clinically essential. For seniors with a history of heart attack, diagnosed heart failure, coronary artery disease, or specific arrhythmias, beta blockers remain medications with solid, well-established evidence. The mechanism that makes them potentially suboptimal for isolated hypertension in an otherwise healthy older adult, the reduction in heart rate and cardiac output, is precisely the mechanism that makes them beneficial in those cardiac conditions. The same drug, different patient, completely different risk-benefit calculation. The conversation here applies specifically and only to seniors whose single diagnosis is uncomplicated hypertension, with no accompanying cardiac indication. If that describes your situation, the question of whether your current prescription reflects the best available evidence from the past 20 years is a legitimate and important one to raise with your physician. Here are 4 specific steps to take with this information. First, identify whether you are taking a beta blocker specifically and only for hypertension. The names to check on your medication list are metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. If one of those appears and your only diagnosis is elevated blood pressure, no heart failure, no prior heart attack, no arrhythmia, that is the situation this conversation addresses. Second, bring 3 specific questions to your next appointment. Ask whether your beta blocker was prescribed specifically for blood pressure and whether that choice still reflects current ACC/AHA guidelines, given your complete health picture. Ask whether your fasting blood sugar, triglycerides, and HDL have been reviewed recently in the context of your current medication, and ask whether you are a candidate for a supervised transition to a calcium channel blocker or an ARB, given what the evidence shows for uncomplicated hypertension in your age group. These 3 questions open a conversation that a standard blood pressure check does not. Third, if your blood pressure prescription has not been formally reassessed in 2 years or more, request a medication review. This is not an unusual request. It is good medical practice. Guidelines evolve. The evidence that was standard of care in 2005 is not the evidence that informs current guidelines. A physician practicing evidence-based medicine should genuinely welcome this conversation. Fourth, if any transition is discussed, confirm the tapering schedule explicitly. Responsible beta blocker transitions are conducted gradually over a minimum of 4 to 8 weeks, with regular monitoring of blood pressure and heart rate throughout. There is no appropriate shortcut. Alongside any medication conversation, the lifestyle variables that directly support blood pressure control are worth addressing clearly, because the evidence for them is strong and they are within immediate control. Daily moderate physical activity, 20 to 30 minutes of walking at a pace that slightly elevates breathing, has been shown in multiple trials to reduce systolic blood pressure by 4 to 9 points. That is a clinically meaningful reduction, comparable to the effect of a low-dose antihypertensive in many patients. Reducing sodium intake to below 2,300 milligrams per day produces reductions of 2 to 8 systolic points in most hypertensive individuals. The DASH dietary pattern, high in vegetables, fruits, and low-fat dairy, low in processed food and sodium, was shown in a trial published in the New England Journal of Medicine to reduce systolic blood pressure by 11 points in hypertensive patients. None of these interventions require a prescription, none carry metabolic burden. all compound with whatever medication strategy is appropriate for a given individual. Medication is one tool among several. For blood pressure, it is often a necessary tool. But it is not the only one, and in many cases, the lifestyle variables have effects of comparable magnitude to low-dose pharmacotherapy, without the side effects. The fatigue when climbing stairs, the weight that has gradually accumulated without a clear explanation, the tiredness that sleep does not resolve. These experiences are commonly attributed to aging, and that attribution is understandable. Aging produces many of them, but there is a specific, documented, well-researched mechanism through which a beta blocker can produce every one of those experiences in an older body, through reduced cardiac output limiting exercise capacity, through insulin resistance and metabolic disruption, through direct effects on energy metabolism. The current evidence base, as reflected in major cardiology guidelines on both sides of the Atlantic, has moved away from recommending beta blockers as the first-line treatment for uncomplicated hypertension. Better studied alternatives exist with stronger cardiovascular outcome data and more favorable metabolic profiles for older adults. You are not required to continue taking a prescription that was written years ago without ever asking whether the evidence still supports it. You are entitled to walk into a physician's office with informed questions and to expect a conversation that reflects what the research currently says, not what it said when the prescription was originally written. Your blood pressure matters. The medication you use to manage it matters equally. The conversation that brings both of those things together, informed by current evidence, is one appointment away.